My paper is muscle transplantation as an effective primary surgery for large angle horizontal strabismus. Large angle horizontal strabismus is characterized with the angle of more than 60 PD for exo or iso deviation, which presents a challenge in its management. There are conventional techniques such as we have a supramaximal recession or resection, three muscle surgery, large bilateral rectus recession, muscle recession with spacers, and hangback or hemi hangback recession. But all these techniques has some kind of drawbacks. And our study, which is a true muscle transplantation, which offers advantage such as preserving the committance and intraocular handling and post-surgical stability. So purpose of our study to demonstrate the effectiveness of muscle transplantation, which is a primary surgical procedure in case of large angle horizontal strabismus. So our material methods, this is a prospective cross-sectional study. We have done around 25 patients who are having more than 60 PD of ESO or exotropia. Muscle transplantation was a primary procedure for done all these cases. The study was done is in RAO Minto Hospital, Bangalore, and we are included a patient who had a large angle strabismus more than 60 PD, and a patient who had given consent, and excluded patient who are having paralytic squint and previous history of squint surgery, and who had a severe FTT test positive and also poor vision patient. So all motor and sensory evaluation was done before the surgical procedure, and this is the case of a large angle esotropia. So this is surgical demonstration. In the video, in the first stage, we are decided that lateral rectus muscle, which is around 7 mm resection was decided, and which was secured with the 60 vicryl suture around 7 mm from its incision. This is the first stage. Once we secured the LR muscle at 7 mm, we have to put one more vicryl suture that is exactly at the incision. So this is a little bit tricky. So you have a 2 vicryl suture. You have to be careful. Don't cut the suture in between. After this, we have to do the resect the lateral rectus muscle, and then we have to cut the incision point so that you will get a lateral rectus muscle stump. So this is the cut part of lateral rectus muscle stump, and this is followed by the lateral rectus resection. That is normal lateral rectus muscle which is left over. We have to suture it to the stump part. That is the remaining stump part. And in the next stage, this is the resected lateral rectus muscle which is sutured to its original insertion site. This is a normal procedure. And the third stage, you have to secure the medial rectus muscle. This is just a resection procedure for medial rectus. Put a 60 vicryl suture at the incision of medial rectus and then disinsert the muscle. And the fourth stage, so this is a very tricky procedure where you have to suture the lateral rectus muscle stump to the distal end of medial rectus muscle. So while suturing this one, you have to be very careful so that it should be very tight. So the muscle should not slip during this procedure. Once you secure the lateral rectus stump to the medial rectus, that is the distal part of medial rectus muscle. After this, the last stage of procedure, lateral rectus and medial rectus complex, which is sutured to the sclera, that is 8 mm away from the original incision in this procedure. This is the last stage. So originally, these are all preoperative patients. So around 12 esotropia patients we have taken. Most all the patients who had around more than 60 PD prism diopter for the distance and near. And there are few residual ESO deviation was left around 10 PD for the distance at the end of 6 months. So follow-up was done for first week and first month and 6 month. And these are the post-op picture. And these are the 13 patient exotropia patient who are more than 60 PD was taken and followed up for 1 week and 1 month and 6 months. And there are few patients who had around residual deviation of exotropia deviation of around 10 PD at the end of 6 months. So all the patients who had underwent above stated primary procedure were followed up for first week, 1 month and 6 months. And mean preoperative angle was 70 PD in 12 patients with esotropia. Mean age was 32 year, and most of the patients were found to be orthotopic except 4 patients who had a residual deviation of more than 5 PD at the 6 month of follow-up. And main preoperative angle of 66 PD for the exotropia patients. Mean age was 22 years, And pre-operative, post-operative angle was left around 4 PD for the 6-month follow-up. And discussion in managing the large angle horizontal strabismus, various technique has been found, but there is a lot of drawback were there, like patient can induce have a severe restriction and incompetence commitance following this procedure, and large resection can cause enophthalmus and palpebral fissure narrowing. So conclusion, why our technique has a edge over others: it does not restrict the ocular mobility and avoid resurgery. So it's done on single non-dominant eye and avoids the surgery on multiple muscles, so you don't have to touch the other eye. And there is no co-contraction of the muscle, which results in narrowing of palpebral fissure and other things. So therefore, muscle transfer surgery can be considered as a good alternative primary procedure on non-dominant squinting eye in very large angle deviation. Thank you.